Today's discussion will focus on the challenges and opportunities in 3D head and neck CTA reconstruction workflows, and how automation with Lumina 3D can have a real impact on CT tech workflow, CT scanner throughput, and support better informed diagnosis using CTAs. Our first speaker today is Leslie Cattau, the Executive Director of Imaging of a large Midwest hospital system. With over 2 decades of experience in diagnostic imaging, Leslie is a strategic leader known for developing creative solutions that drive quality, efficiency, and operational excellence. And later on, you will hear from Dr. Raza Mushtaq, a board-certified neuroradiologist at Barrow Neurological Institute, where he serves as the Director of Head and Neck Imaging and Associate Program Director of the Neuroradiology Fellowship. We are honored to have both provide insight on Lumina 3D's impact. And with that, I'll turn it over to Leslie.
Good morning. Thank you, Sohail. So happy to be here. I appreciate Rapid giving me the opportunity to share my story. And my goal with all of these talks is just to connect. It's really to just connect with those that are sitting in my seat, to bring experiences that maybe somebody can get some impact from, that maybe get some ideas, maybe get some ahas, or maybe it's just you're not sitting alone in the seat, because we are all facing some of the big challenges with healthcare. So with that, I appreciate being invited to this event. So we're going to jump in. I'm going to just start by sharing a little bit about my organization and the journey that led the organization to Lumina 3D. So first of all, we're located in the Midwest, and we operate across a broad catchment area. So our imaging services have to scale a large and diverse patient population. We are in a very, very, very competitive market, as are many organizations. We are not unique in that sense. But therefore, any quality gaps, whether they are real or perceived, are highlighted quickly, because a lot of our specialty physicians work across multiple health systems within our very, very tight region. Our team performs over 82,000 CTs annually across 10 scanners, obviously not including SPECT CT or PET, which some count those as regular CTs or not. And of those 82,000, 3,800 of those are CTAs. Additionally, we have 38 CT techs, both full-time travel, that's including PRN, but I also want to call out half of those are dual modality trained and certified. So we usually run on about half of that, because half of those are doing also MR or a secondary modality. And as we all know, CT scanners are one of the most expensive investments a health system makes in the imaging department, or actually across all areas. And really the only way to increase an ROI within imaging, historically that is not necessarily the case today, is just to do more patients. And so we have to be very cognizant about creating efficient workflows, minimizing our downtime, and really keeping highly engaged team members to maximize the utilization of the system. Granted, that was the historical model, but now as we get into some additional technology and AI and processing platforms, we do have opportunity to increase revenue in some of the arenas with some additional billable codes, which we'll talk about in a little bit later. So what got us started on our journey with Lumina? Well, of course, it starts with challenges. Don't all changes start with a challenge. So there are really two key factors that really kind of sat us down and realized we really needed to evaluate our situation. So one of the challenges that we identified was very slow CTA turnaround times. And the second challenge that we identified was we were having an increasing number of discrepant reports between prelim and finals. It really just became a whole thing with our medical staff. So we really had to step back and assess the entire workflow. Like, why is this happening? Trust was eroding with our specialists. It was so painful, and essentially we just had to fix it. And I'm a leader that I really sit down and I think about, like, why is this happening? Like, it was it was fine last month, but now it's not fine. So why is it not fine? And what it really boiled down to is we had an interesting shift in our organization at where we were historically in years past really just a bread and butter organization. I mean, we were a health system that was just it was very community-based healthcare. We didn't have a whole lot of subspecialties, but we really excelled in primary care. Over the last couple of years, the organization has really made an intentional shift from being that community-based bread and butter organization to more of a market leader in really targeted subspecialties, one of which is neurology. So established a neurohospitalist program, a neurosurgical program, became a mechanical thrombectomy capable site, and those becoming the targeted subspecialty areas is really what elevated that quality threshold. And so it wasn't so much that what we were doing before was bad, it just no longer met the elevated criteria of a subspecialty healthcare organization. So it was interesting, once I understood that, the pathway became a little bit more clear. So that was just a little background nugget to our world. So really to evaluate our imaging workflow, because we knew we had to figure out what was the key driver of our delays. We really needed to draw out and really define what our workflow looked like existing. And so we could really time each step and understand exactly what was happening within each step. So we could really go back and put targeted strategies around the areas that we identified. So as we know, time and speed matter, especially in stroke and trauma situations. We all know that. So I'm going to just walk through our workflow as it was before, and this is going to align with any of you that sits in a similar seat, because this is your very standard, typical workflow for CT. So patient arrives, scans completed, and again, we do about 3,800 CTA head and necks a year. And then the tech will do the manual reconstruction on the images, send them to PACS, the rad reads them, results get sent out. So again, very, very linear workflow. So what we identified was this linear workflow is really where we were losing time, because nothing could happen until the prior step was complete. So a few items really jumped out when we started doing this PDSA and this quality study. Is what we found out was it took us on average 31 minutes to post-process a CTA head and neck. So keep in mind, that was the actual time it took to do the post-processing. That was not including the time of delay that maybe came into play because they had a competing priority. So keep that 31 minutes in mind, because that will come into play down the road as we talk about outcomes a little bit more. So as we did this PDSA study, we really identified three key challenges, three key barriers that we needed to find a way to overcome. One is we had dated CTs and post-processing technology. I know that is not a new concept. I know everybody sitting out there is saying, yep, less, same. So with that manual post-processing technology, it was on a separate workstation, separate application, having to log into it, make sure the images got over there. It was just a whole messy thing. And then because of our high utilization, we have prioritization challenges. So do the techs pause scanning, the next patient, so they can post-process this one? Because what if it's a trauma that comes in? What if we have 3 strokes that land at the same time? Well, what do we do? And so that played into the delay. Our current CT scanners have no post-processing automation within the system itself, as some of the new scanners have. So we had everything against us in that post-processing arena. And then the second challenge that we had was we have varying levels of staff experience. As we all know, CT techs are very hard to come by, to be able to hire an experienced one. So really, you're constantly training from new graduate up. I mean, we're just training babies, right? And what we found when we were capturing our data was that we would have CT techs that could post-process in 15 minutes, and then we had CT techs that were post-processing in 45 to an hour. And so it was very inconsistent. So not only was the time inconsistent, but then the outcome was also inconsistent. So there was not a high level of trust of the results, because there was such a big disparity in what was being in the outputs. So that was a secondary challenge. And then a third challenge that we mentioned a little bit earlier was that high scanner utilization, and which that leads into the creating prioritization challenges. We looked at the workflow, we found our barriers, and now what are we going to do about it? So sat down and we really worked through a list of mitigation strategies and how we wanted to approach, because being a very conservative organization, we want to try to enhance, utilize, fix existing systems to make sure that they are being utilized at their highest capacity before we start looking for outside solutions. So that's what we did. Number one, obviously, was, okay, give me a couple $1,000,000 and we can replace the CT scanner. Yeah, we all want that. Last time I checked, my capital tree has not been fertilized. So we kind of had to scratch that one off the list for now, because the scanner itself was not an end of support. It's their workhorses. From a technology perspective, they were fine. So we kind of took that off of the list. So second, there was an upgrade option for our existing post-processing software that it was marketed to actually include automation and significantly reduce reconstruction timeline. So we got really pumped and excited about that. So we waited some time, got that update done, redid the education on that, and it maybe took off 1 to 2 minutes. It just did not perform as advertised. So that was a disappointment for us. So then we went back and we're like, okay, maybe if we get consistent education for all the technologists, and maybe we can make those longer turnaround times of 45-minute to an hour. Maybe we can get those down to 30-ish. We would be okay. It would help enough getting that linear workflow down. So we went through that exercise, and we had vendor-supported post-processing training for all the technologists. And unfortunately, we did not see the outcomes that we were also hoping. I mean, it helped a little bit, but again, because of that cycle of constantly training and onboarding more CT techs, because we are just growing so fast, we're just constantly adding positions, it just wasn't enough. And then because of our utilization, we really evaluated load balancing across our scanners and our sites. And while that helped decrease like that order to scan time on the very front end of it, especially for ED and inpatients, it was not enough to overcome that reconstruction time delay. So again, tried 4 mitigation strategies, really were unsuccessful with all of them. So really, because of that inability to overcome these barriers, we really sat down and were like, okay, now what? What do we do now? And that's when we kind of turned to AI in general and said, like, okay, we need something different than what we've been doing. And Lumina 3D came across my desk, and I looked at it and I'm like, whatever, okay, been there, done that. We already went down a road where it was marketed to reduce the construction or reconstruction timeline, and that wasn't successful. But we decided, since we already had worked with Rapid on our stroke platform, we're like, okay, you know what, we'll give this a try. So we moved forward and deployed Lumina 3D. And I'm here to tell you the outcomes were very, very immediate. Very immediate. It was within an hour of us going live. I had a radiologist land in my office, and he's like, Les, this is awesome. I'm like, okay, all right, we're in business here. So, and he was one of my rads that was super hard to, get excited about something. So this was a big deal. So really what we found is that it took our previously linear workflow and made parts of it parallel. And so while the patient, obviously the front end of it still is linear, the patient arrives, we do that CT head and neck, and then that's where it splits into now a parallel workflow. While we send the images to Rapid, they post-process them, bring them back. And at that same time, the tech's able to finish up the exam, get everything ready. And then they kind of hit PACS at the same time. They hit the mobile app, they go to the web. So now we can have the radiologist reading at the same time the subspecialist gets notification or is able to see it in the app and make real-time decisions, and really not even sometimes have to wait for the radiologist report. And so that treatment decision timeline just really, really shrunk down. And so for us, that was our primary victory. That was what we were setting out to do, was just for every individual patient, shrink down that timeline so we can get to a treatment decision faster and improve outcomes. So we saw both operational and clinical value. I mean, it was immediately. And really that was rare for us, or for myself. I don't want to say for everybody. I have seen it be rare that adding a new tool has that much of a clinical impact that immediately. And so I'm going to touch just a little bit on the implementation, because I know that's also important, because some tools and widgets require, a lot of IT engagement, a lot of infrastructure changes. And for us, this was very, very, very easy. Because we're already a Rapid stroke customer, really all we had to do was upgrade from an on-prem server to the edge cloud that would allow us to transition to Lumina. And that was super simple. And again, I'm not IT, so I may be downplaying a little bit, but the feedback I received was it was super simple. And so once we upgraded it, it was a very easy lift. Our IT department didn't even consider it a project because of how little IT resources were required to get this application up and running. Okay, so now let's talk a little bit about the outcomes. There were a lot, and I was pleasantly surprised. So after 30 days, we kind of let it sit for 30 days, let it process through. We sat down and really measured the impact, and we measured the outcomes because of the substantial preliminary findings that we had. And so the biggest one that was noted was our reconstruction timeline went from an average of 31 minutes to 7 minutes in the first 30 days. And so when you break that down, that is 24 minutes per CT tech time saved. I'm going to repeat that because there's a lot. 24 minutes. And I recognize 31 minutes is probably on the excessive of the high end of post-processing time. So I fully recognize maybe not everybody would experience that much of a decrease, but that was our outcomes. And so I'm kind of a math nerd, if you will. I'm all about data and using data to tell a story and to get buy-in through data. And so I pulled out my napkin math and I just started going to town. So if you take 24 minutes times the number of scans that we did in that month, in that 30 days, we had 72 hours of tech time saved in the first 30 days. What gains can we have from that? What are our learnings from that? So we sat down and we're like, wow, we can add multiple slots to our CT schedule without really impacting anything, without extending hours, without creating new shifts, without adding resources, by just using that time saved. And so while the math said we could add up to 8, we really just chose to do 5 because we really value our team and we were really concerned about their burnout, and we didn't want to re-stress them to the same point. But we also wanted to impact our backlog that we had in CT, and that was actually ended up being a coincidental positive outcome of this, is we didn't enter this as a strategy to reduce backlog, but that was a coincidental result of the application. And so taking that 150 slots that were added, assuming all filled, let's just make assumptions here, that's adding about $61,000 a month in actual imaging revenue, not billed charges. And that's using an average of about $405 per CTA scan. So not only did we get it done faster, we're getting more consistent quality. The RADs now have no question of the output that they're receiving. It's consistent. The neuroradiologists, they trust it. They aren't questioning who did the reconstruction to know like how much they can rely on the accuracy. And so, all this was just a very meaningful bonus is the impact to our access. So really, as I wrap this up, my final thoughts are this. While our primary goal of implementing Lumina was to improve the quality of care of the patient that was just in front of us, get those results faster, the additional revenue opportunities and reduced pressure of the CT team was just an added bonus, which we were super thrilled with. So with that, I will turn it over to Dr. Mushtaq.
Thank you, Leslie, for your incredible insight on Lumina 3D's impact. Next, we will turn it over to Dr. Raza Mushtaq.
Thank you, Sohail, so much for inviting me to talk to you guys today about Lumina, one of the newer Rapids products. We were very excited to have something this unique. Like Sohail said, my name is Raza Mushtaq. I'm an assistant professor of neuroradiology at the Barrow Neurological Institute. We're a very high volume practice. We do about 100,000 CTs per year. A significant number of those are CTAs. As a result, because we are such high volume, we really want to be as efficient as possible, particularly in our tech workflow, because that ends up being the bottleneck for us. And this is where 3D Lumina really comes into play and makes a huge difference in saving up the tech time and getting us the images at the right time, so we can provide a faster read to our clinical colleagues, who are very, very thankful that we are getting through these studies at a much faster rate. So to get started, normally we get reconstructions from multiple sites. So we have our main ED, and then we have at least 3 freestanding EDs and a couple of smaller clinics that all have CT machines. And they all have different techs. They have techs that rotate through, and they all provide very different manual reconstructions. And this is example from one evening call. So like you can see how like there's 5 different cases, and all 5 reconstructions looks very, very different. This is just not consistent. And because these are not consistent, this becomes very difficult to use it in clinical practice. So it's like, in order for me to evaluate each one of them, I have to really take my time, get oriented to what I'm looking at. And because of how long that will take me, this often become very difficult to use in clinical practice. In order to use this in clinical practice, we really want reproducible images where I don't have to spend a lot of time getting oriented to the image. As soon as the 3D reconstruction pops up, I'm able to look at it and say, okay, I know where I need to look, what am I looking at, as opposed to just trying to decipher like where the anatomy is and where do I need to focus. And that's exactly what 3D Lumina does. It provides reproducible 3D reconstructions for every single case. Here's another case from the same call night. This patient had a known left ICA occlusion, and they had a prior CTA where they had a area of stenosis in the right ICA. And on the newer study, that area of stenosis got worse. Well, on the CTA part, I could see that the reconstruction made that even more clear. And here's a bigger bigger field of view where you can really appreciate how the area of the stenosis in the right cervical ICA got progressively worsened over time. And this is exactly how this product adds value. And even 3D reconstruction adds value. This is why 3D reconstructions were meant to be created in the first place, but because of inconsistent reconstructions, these really often fell out of favor by radiologists and do not get routinely utilized in clinical practice. But this is a perfect example where you can see how these two images that were obtained on two different scanners resulted in a very similar reconstruction, which then allowed me to utilize this for clinical decision making. As an example, these were the reconstructions that were provided by the technicians, the CT techs, on the same cases. So this is the 2024 and 2025. Again, very inconsistent images. Even though you can appreciate the area of stenosis, just the inconsistency makes it very difficult to use this for clinical interpretation. Like, I can see that there is an area of stenosis on the new scan, but can I reliably say that this area of stenosis and that's getting worse is because of technical differences, or if that is indeed true progression of the stenosis? And that is just incredibly difficult to do so on the images provided by the CT machine that get automatically generated. But this is exactly where 3D Lumina comes in. It provides those reproducible images so I can confidently make the diagnosis and use that for clinical decision making. Here's another case of ICA aneurysms. Again, reproducibility matters a lot. So here's a case of a patient with two aneurysms, and this region tends to be one of the trickiest regions when we're looking for aneurysm. This area where both of these aneurysms is surrounded by the bone, and the bone has very similar appearance to the contrast in the vessels. As such, these aneurysms can start to blend into the bone and can really hide and can be missed very often. And having 3D reconstructions, particularly in this region, that are reliable, can significantly increase in our ability to identify these aneurysms more confidently. Here's the same patient. This image to the left with the red arrow is an MRA image. And normally, when we do want to evaluate aneurysms, particularly in this region, we prefer time-of-flight MRA images. We get the time-of-flight MRA images and we reconstruct them, and then we use the 3D reconstructions in our clinical decision-making, and we're really relying on these 3D reconstructions. You can see that the Lumina 3D reconstruction is very comparable to this MRA image, and as such, it really starts to bridge the gap between these MRA and CTA images, where we can use CTA reconstructions to compare them to other compared to priors that have aneurysms. So one of the things where I think this really adds benefit is that now we're really bridging the gap between CT and MRI machine, MRI scans. Normally we think of MRI as more as higher resolution images, but not everyone has access to MRI machines. So most patients that are getting worked up using CTAs, but because there's just lack of MRI availability. But these 3D reconstructions allow us to get reconstructions that are similar to what we get from an MRI machine, and thus bridging that gap between those two modalities. Same patient again, another aneurysm you can see on the MRA reconstruction. It's superiorly projecting about the left cavernous ICA, readily identifiable on the 3D reconstruction by Lumina as well. And this is the images, the source data of the CTA, and it can be often difficult where the aneurysm is. Both of these images have an aneurysm, and it can be much trickier to identify those aneurysms on these source data, even though we heavily rely on the source data to make our clinical decisions. But aneurysms, particularly in this part of the anatomy, becomes a lot trickier. There's a lot of curvature of the vessels themselves, which makes it difficult to say whether it's really a true outpouching or is the vessel just curving. So reconstructions is really, really significant in this part of the brain, particularly to make those clinical judgments. Another area where Lumina does a much better job is just dealing with venous contamination. So both of these images are reconstructed off of the same data. On the left, you can see that the scanner produced a fairly decent reconstruction. However, there is contamination. You can see the internal jugular veins being opacified through and through, and that's because whenever we do whenever the scanner does the reconstruction, it's really relying on a on Hounsfield-based measurement. So it's looking for a certain Hounsfield unit, and in anything that has that Hounsfield unit, it will include in the reconstruction, and that's how those reconstruction gets done. And whenever you're using that kind of very basic reconstruction format, you are going to run into the issues where any sort of venous contamination, you're going to run into issues. Let's say there was not enough contrast on board, you're going to run into the same issues where the arterial vessels are not going to get reconstructed appropriately. But Lumina really overcomes those, and it does so because it is based off of a neural network. So it is taught to identify the four major vessels, whether there's poor opacification, whether there's venous contamination, and it does so by segmenting out those four primary vessels and then reconstructing around it. And so even if there's venous contamination, there is early contrast bolus timing, or there's not enough contrast on board, the 3D reconstruction done by Lumina will help, will overcome those limitations and provide a much better reconstruction. One of the other regions where areas where 3D Lumina product really comes in, and I think is an excellent, is probably the most valuable for me, is going to be the automated curve planar reformats. So these curve planar reformats can take quite a bit of time. This also requires the tech to know the anatomy really well. So if you have a traveling tech, or if it's a tech early in their career, they may not be very familiar with the anatomy. So even if they do the curve planar reformats, they might not do it appropriately. And having this curve planar reformats matters quite a bit. So here's an example of the same patient. Using the curve planar reformats to define the area of stenosis is really the best way to do so. Currently the vascular surgery guidelines say that anybody that has 70% stenosis of the ICA is a surgical candidate for carotid endarterectomy. In those patients, being able to accurately say who has 70% or greater stenosis is extremely important. Let's say a patient has really, indeed have 60% stenosis, but you do not have the curve planar reformats, and you're just using your basic multiplanar reformats or axial images to do your NICET measurement, then you're gonna and you overestimate that 60%. Now suddenly you made that patient a surgical candidate when they were not, and vice versa is true as well. Let's say they had indeed an 80% stenosis, but you underestimated it because you did not have the curve planar reformats, and now a surgical patient who would have significantly benefited from surgery is not going to be eligible for it. So curve planar reformats really allows you to get a good look down the barrel and better characterize the percent stenosis, and do so more accurately than your general planar multiplanar reformats in coronal and sagittal, just because the tortuosity of the vessel itself is going to be significantly impact where the stenosis is. Moving on, why do we get these 3D constructions? These are heavily recommended by ACR. ACR, American College of Radiology, says that any CTA study, whether it's in the head and neck or whether it's in the body, requires getting 3D rendering and multiplanar reformats. This goes back to the early days of CTA. They said that this is the best way to evaluate any CTA, and it really does. You really do need these 3D reconstructions to get a good idea of what's going on. It provides you It's always supplementary to you, to the radiologist looking at the images on the source data. So it really adds significant value because it allows for better characterization of the underlying pathology. And that's really what ACR's goal was, to mandating that every single CTA gets a 3D reconstructions with it. And that has really translated into billing as well. So CMS says that in order for you to bill for a 3D, for a CTA, it has to have a 3D reconstruction that goes with it. In order to bill for any CTA, whether it's CTA head and neck or CTA chest, CTA, CTA lower extremity, you have to have 3D reconstructions. And not only you have to have 3D reconstructions, you have to document it that you have done a 3D reconstruction. So both of those things have to be there. You have to do the 3D reconstruction, and it has to be documented in order for you to bill it as a CTA. If you do it, the 3D reconstruction, but you don't put it in the report, it gets downgraded and gets billed as a CTA. So in a case of a CTA neck, the technical reimbursement ends up being around 4 or 5. But if you do not document that you did the 3D reconstructions, you get paid at 196 approximately. So you're losing about 50% of the revenue just by not documenting it appropriately. Or if you didn't do it, then you can't document it, then you're still losing 52% of the value, even though you did a true CTA sequence. So what is the best workflow around it is, from a radiology standpoint, the radiologist should have this automatically in their template. So anytime a CTA comes in, you're able to, the technique already says that 3D reconstructions were done, and the radiologist is actually double checking that 3D reconstructions were done and actually using them for clinical decision making. And they look at it, they double check it's there, and then they sign it. The problem that ends up happening is if you just make that part of your template, but you're not consistently doing it, then you are overbilling. So technically, you're not allowed to bill for a CTA if the 3D reconstruction is not there. So if the radiologist has as part of their template, but the tech forgot to do it and the radiologist forgot to check for it or forgot to take that out of the technique, then you've just overbilled, and that can come back to you in auditing. So the best way to do it is that the 3D reconstructions get done every single time. No better way to do that to an automated way. And then from a radiologist standpoint, that's just part of their technique, so they don't even have to add it or think about it. They're just double checking it, and then they hit sign that the reconstructions were done. So you're then able to bill for it appropriately. There are alternatives to an automated way of doing it. You can have internal 3D labs. We looked into that very briefly. There's just a very high cost to building it. And part of that goes with the staffing requirement. So let's say if you only hire one person for during the daytime, then what do you do during evenings or nighttime? So do you get another person during evening and nighttime then? What if that person, you have to give them vacation, even if there's a daytime person? So you really need at least 2 people to be doing that. So what if, like there's only 2 people on and suddenly you get like 20 studies for some reason, right? Like you get a CT heart, CTA chest, CTA neck, CTA head and neck, which we often do. Like, we have several scanners that are scanning at the same time. So it's not infrequent for us to get like 5 CTAs within 1 minute time period, because there's like 5 different sites and they can all be doing CTAs and all of them come at the same time. So at that point, the internal the lab person has to decide, okay, which one do they focus on first. So let's say, they focus on one of the studies from the main ER, and they're holding off to doing reconstructions on a scan that was done on the outside ED for us, then we've just delayed diagnosis. And what if the person that we just delayed doing the 2D reconstructions actually had an abnormality, like a dissection that required us looking at it sooner than later? So anytime you add this another layer of another person who has to look through the images or do something, you're always adding that potential to delay in us getting the images, and that is very significant. There have been many times where the ED will call me and they're like, hey, this CTA neck was done like an hour ago. Why is there no read? And at the moment we have our own tech do it. So we're like, well, I have and the tech hasn't completed the exam because they're waiting on doing the 3D construction. And we tell them that, and they're like, well, we think this person has a dissection, and lo and behold, we'll look at it and they have a dissection, and I just didn't get to look at it because it wasn't even on my list, because we were waiting on somebody to do those 3D reconstructions. So having an automated way where the tech doesn't have to do it, as soon as a scan gets done, the 3D reconstruction gets automatically generated and the study comes to your queue is the best way to kind of proceed. One of the other ways you can do it, there is an alternative of outsourcing these 3D reconstructions. I think that runs into the delay in diagnosis even more. It becomes much trickier to do CTA necks, especially in the trauma settings with those scenarios. And CTA necks are becoming more and more common in the ED setting. The guidelines say that you can get a CTA neck for like varying degree of trauma. Like if you have a mandible fracture, you should be getting a CTA neck. So we have seen a significant increase in number of CTA necks that we get through the trauma setting, and those are ones we cannot wait for turnaround time of an hour, and that's mostly what this outside reconstruction companies will do. They will require at least 1 hour, and which is really technical, right? Like you have to send the images to them, and somebody has to receive them, then they have to reconstruct it, then it has to be sent back. So even just that sending back and forth adds time, which often, like in these scenarios, it's really not necessary, and can cause harm to the patient in the end. And the main thing with this outside reconstruction is there's still going to be variability in quality, because it's not going to be the same tech who's doing these 3D reconstructions again and again. So then you're going to have like the reconstruction that comes through is going to look very different from patient 1 to patient 2 to patient 3. So then it goes back to the same problem we discussed at the beginning, where it's difficult to rely on these for clinical decision making, where you're not able to really utilize them consistently, because it's difficult to get oriented to it in itself. Then you are using it, and then you're trying to decide whether the abnormality that you're appreciating is really technical or is it true. So it really runs into that variability problem again. It's not consistent, and then more importantly, the delay in diagnosis really ends up being a very big hindrance to why these outside reconstructions really fall out of favor for us. So in conclusion, Lumina 3D has been excellent to free up CT tech time, which means we can scan more patients. We get through more studies every single day. More importantly, from radiologist standpoint, we get consistently high quality 3D images because we are getting that reproducible and consistent in 3D reconstructions. We actually use them to make clinical decisions and do so quite confidently without thinking about whether this is artifact or not. And that has really been instrumental for us to fulfill what ACR said to recommend in their guidelines why these reconstructions should be doing. It has helped us with billing quite tremendously. We make sure that we are billing consistently every single time, and that's really where Lumina has been instrumental for us. Just from a diagnostic standpoint, we are able to be more confident, and we are able to bill for these consistently at the appropriate level. That's all I had. Thank you.
Great. Thank you, Dr. Mushtaq. So our first question for our Q&A section. RapidAI performed a survey of 50 imaging directors around the US, where almost 2/3 of the respondents stated that outsourcing reconstructions have a very long turnaround time. What were some of the reasons why you didn't pursue outsourcing 3D reconstructions to an external vendor?
Full transparency, it never crossed my mind. And I believe the reason it never really crossed my mind to evaluate it was because culturally as an organization, that is really not our model. We do not outsource many of our services. I mean, I'm sure there's some in there, in the organization somewhere, but that's really not been, and nor do I foresee it being a model of the organization. So it really never even crossed my mind. Plus, what I did know about it, it was super cost prohibitive because we are also a very financially, fiscally conservative organization. And so, as we mentioned earlier, we went through all the strategies, the low cost strategies before, even looking at something that was going to be a cost to the organization. So that's essentially why it never even crossed my mind based on the culture of the organization.
Thank you, Leslie. Can you give advice to those on the call? How do you champion technology like Lumina 3D within your institution?
My sarcastic answer is by proving nothing else worked. And I think that was is a demonstration here is like, when you try everything else first and you're still not getting the outcomes that you need and are expected of our physicians and our patients, you have to do something different. And that is how I've been able to get some leverage and some momentum around imaging AI, just even in general outside of Lumina, is by demonstrating and being very thoughtful and mindful about the technologies that you are bringing in. Just like in this situation, we were very mindful and very about what we were trying to accomplish. We don't just entertain widgets that show up at our door just because they're cool and they might be helpful. We really look at it through the lens of what problem we're trying to solve. And if we demonstrate we are unable to solve it through the normal means, that's how I've been able to get traction with some AI technology. And also that also demonstrates to the physicians that there's always this fear of, okay, is AI going to take over my job? And what some of these use cases have demonstrated to some of the physicians is that no, it really isn't. It's really about how do we make your life better so that you can be more efficient. And so slowly over time, that mindset is shifting by case studies similar to this. So it's not just one application that's ever going to shift a culture, but it's really demonstrating positive organizational outcomes by utilizing these tools. That was a long-winded answer.
So question for you, Dr. Mushtaq. What types of diseases do you find Lumina 3D being most beneficial outside of just carotid stenosis?
I think really any abnormality, any pathology that occurs, it's going to be a lot easier to appreciate this. Well, the fact that you're getting this reproducible reconstruction really allows to have more confidence in my ability to make the diagnosis. So even if there's a dissection that's going to result in luminal narrowing, I'm going to be more confident that what I'm looking at is indeed luminal narrowing and not just artifact, because that's how the CT tech ended up doing the reconstruction. This becomes very, very helpful for our neuro-IR colleagues who are doing pre-op planning, pre-treatment planning for whether they're about to go take out a clot or they're about to go fix an aneurysm. So it really ends up being a plethora of pathology ranging from what we just discussed here to really any reason why we end up getting a CTA. So it really does add value. And I think this really goes back to what ACR why ACR recommends these 3D reconstructions. They really, ACR really believes that this is the best way to look at images, and we do agree with them.